Oncoplastic breast surgery is a concept which has evolved with time. I remember when we were training in the late 90s and early 2000s, we were pushing for more patients to have what we call lumpectomy or breast conservation surgery. However, it soon became apparent that we were probably doing a disservice to a group of patients. And the reason for that is you can remove a cancer. However, if you leave behind a cosmetically deformed breast, that doesn't serve, that does not serve any purpose to the patient. In fact, it is a cause of concern. And in one study, nearly 20 years ago, it showed that nearly 60% of patients were unhappy with the shape of their breast and the cosmetic outcome. This prompted almost a revolution in concept of how to do breast conservation surgery. What we have to remember is there are two aspects of it. One is we have to provide a cure for the cancer. So oncological safety is of paramount importance. You cannot compromise on it. But in addition to that, you not only have to take the cancer out, but also reshape the breast so that patients do not have the cosmetic problems that we were seeing 20 years ago. This prompted a change in our practice, and we had to remember that most of our patients who had breast conservation surgery or lumpectomy, they would need radiotherapy. Therefore, not only the concept of oncoplastic surgery had to make the breast look right after the operation, but also it had to look right after radiotherapy because radiotherapy does cause changes in the breast texture. So for me, anybody having a breast conservation surgery, oncoplastic surgery is a must. Now, in surgical parlance, we divide the oncoplastic surgery to different levels. So for example, if somebody is having a small cancer removed where not much tissue is being removed, you do not need a lot of oncoplastic techniques. A simple void local excision is sufficient. However, if you imagine the volume of tissue which is removed as a percentage of the breast tissue, that is where the more sophisticated and the techniques come in, where we use either to reshape the breast or even use fillers in the breast to maintain that shape. So oncoplastic surgery is for everyone. It is the level of oncoplastic surgery which has to be determined by the surgeon. So oncoplastic surgery, as I said, is reshaping the breast. And as we know, it is an extremely important part of a woman's body. It defines their feminism, it defines their beauty. The two aspects of the oncoplastic surgery is how to maintain the breast mount to make it look right, and also the position of the nipple in relationship to the breast. So there are various points of measurements that we consider. And if you look at it, the most of the work of these things have been done by our friends and colleagues in Italy and France. And they have taken a lot of inspiration from Renaissance painting. So if anybody's visited the famous Uffizi Gallery in Florence, or Firenze as they call it, there is a very famous painting called Venus of Urbino. And the Italian surgeons were very clever in using the Venus in Urbino as a point of reference. So when we think about it, how much we can reshape the breast, that is a template that we look at. And the template basically has been scientifically modified so that it can be used by everyone. And the basic parameters we'll look at is the shape of the breast in relation to the chest. And therefore, the distance of the nipple from what we call the sternal notch, which is this little thing we have here, the distance from the nipple to the inframammary fold, which is the lower part, the base of the breast, and the width of the breast. So all these things are considered when we consider breast oncoplastic surgery. When we talk about breast oncoplastic surgery, there are two ways of doing it, and it all depends on the volume of tissue that we remove to do the cancer surgery effectively. If we use less than 10% of volume, then there's very minimal reorganization or reshaping of the breast is required, or even changing the position of the nipple. If we start to take more, 10 to 20%, then we have to do something so that that gap in the breast is filled up and not affected by the radiotherapy and cause a deformity which is dipping into the breast. In addition to that, if you go beyond 20%, beyond 30%, then you have to really reshape the breast. One technique is to do what we do with breast reduction, and that is complete reshaping of the breast, making the breast smaller. And in that case, you have to consider contractile surgery to maintain the symmetry of both sides. And also, it makes the surgery more complicated, so the patient has to understand what are the possible complications this may impact. The other way of doing it is, if the breast is not big enough for a breast reduction, then consider taking the volume of the tissue out and then filling it in with what we call local perforator flaps. Common ones are flaps used from the side of the chest wall, what is called the LICAP, L-I-C-A-P, LICAP flap, or what we call the MICAP flap, where tissue from just below the inframammary fold is used with a vessel which runs into it, which keeps the flap alive. And it not only gives us filler to fill in the cavity that we have created, but also can also provide us some skin if we have to take the skin overlying the cancer as detected by clinical examination, that this may be closed and therefore is important as part of the cancer surgery. So in short, we call it volume displacement or volume replacement. So volume replacement is when we need external fillers. Volume displacement is when we can use the breast tissue, which is already there, to fill in the gap. A word of caution, there are certain areas of the breast which is more easy to do, some areas of the breast which are more difficult to do. And the most difficult area to do is the upper inner half of the breast, which is close to the breastbone. And this is the area which is technically the most challenging area to fill up. So there are different levels, and your surgeon should be able to advise you what is best for you. Everyone is a candidate for breast oncoplastic surgery. However, the two things that we have to keep in mind. Some patients prefer not to have more extended wounds or donor site, and we have to respect that. The second is, sometimes we come across patients who have health issues, which provides us a challenge in giving them general anesthesia. So in those cases, sometimes we have to accept that, explain to the patient, and do the simplest operation to make sure the patient goes through the surgical process in safely and without too many complications. The two patient considerations, patient factors that we look at is what can affect their healing. So the two challenges we have is, one is smoking, and there are certain health conditions which makes healing difficult. Say, for example, diabetes, or anybody who's on any immunocompromised medication for other diseases, or have connective tissue disorders like SLE or scleroderma. They have difficulties in healing. There's also another group of patients who are prone to develop hypertrophic or keloid scars, and that is something which is quite evident from history. And we have to explain to the patient that any scar we do, even the simplest scar, may end up in keloid scar, which is a thickened scar, widened scar, and can be very itchy and problematic. So we cannot avoid that even with simplest of surgery. However, more scars we provide, the patients may be more at risk. So those are the only areas when we have to be honest and have a conversation with the patient and explain where things may not go right for them. So it's up to the patients to choose, but it is our duty to discuss this. One of the biggest positives of oncoplastic breast surgery is promoting breast conservation. Now, if you look at the history of breast cancer surgery, just over 100 years ago, a gentleman called Halsted in USA promoted this idea of radical mastectomy. And that was the only thing which provided long-term good outcomes for patients. But we have moved on. And we've moved on because the concept of breast cancer treatment has changed. Halsted said that breast cancer is a local disease, so we have to be very, very radical with our local surgery, where he took away not only the breast, but also some chest wall muscles, all the lymph nodes in the axilla. Then came a gentleman called Fisher, again an American person, who said that breast cancer is actually not a local disease. It is a disease which affects the whole part of the body. So we not only have to consider surgery as the mainstay of treatment, we have to consider other treatment. And that's where the chemotherapy came in, the radiotherapy came in, the tablets like tamoxifen came in. And this revolutionized our concept of it. And then in the 70s, when the modified radical had changed to a more simpler mastectomy, the Italians thought whether we can do just a lumpectomy. And initially, the lumpectomy was quite extensive, what we used to call quadrilectomy, where almost a quarter of the breast was removed. This not only raised the concern about poor cosmetic outcome, but also they realized that without radiotherapy, there was a high incidence of local recurrence. Then we moved to the next stage where we knew that radiotherapy and our other treatments are effective in conserving breast. So now we're pushing more patients who can have less deforming surgery with mastectomy. And what we know psychologically for a woman, keeping the breast is much better than even the best quality breast reconstruction eye or anybody can provide. So it is very, very important that we consider this. We are in an era where we're calling for de-escalation, and de-escalation is in terms of treatment, where we are providing treatment which is appropriate for the patient. So it's not a blanket that this one size fits all. Same is true for surgery. Therefore, we have to move to an area where we can do more and more breast conservation. We are pushing the boundaries. We are in an era where we're calling this extreme breast conservation. And very interestingly, there's been a few papers which have come out, one from a Scandinavian country, the other from Australia, which is not top level evidence, but there is a trend which is emerging. And we have to be honest, we don't understand what this trend is. But the trend is that the overall survival is somehow better in patients who are having breast conservation surgery compared to mastectomy. And this is stage matched. So there must be a reason why this is showing. However, this has not been tested out in a high quality trial. And therefore, we have to be a bit cautious with what interpreting it. But we cannot deny that there is some trend which is emerging. And therefore, it is an opportunity for us to discuss with patients how doing breast conservation surgery is not only better psychologically, but probably, and I say probably with a hint of caution, may be better, we don't know yet, for long-term outcome. And also what oncoplastic surgery provides us is that often we know that if we do a lumpectomy in a lady with very large breasts, once you treat the breast with radiotherapy, there can be quite a bit of effect. The breast can get heavy, the breast can feel unnatural. And we know that the effect of radiotherapy in a larger breast may not be as good. So this may be an opportunity to make the breast smaller, to make it more practicable to give radiotherapy and get not only good cosmetic outcome, but also good outcome in terms of oncology and also patients' well-being. Everything has its advantage and disadvantage. The disadvantage is that we are doing more extensive surgeries. We are producing a lot of scars, and some of these scars can prove a bit difficult to heal. We are operating on the other side, which is otherwise normal. So we are operating on a breast which is otherwise normal. Um, the other disadvantage is that obviously the recovery is slightly longer, but these are all short-term issues. In the long term, um, in generally, orthoplastics breast surgery has very few disadvantages, but the most important thing, it has to be done on the right person with the right information given to the patient. So it is a shared decision making process where it is our duty as surgeons to provide our patients the best advice and give the patient the chance to mull over their choices and give us what they feel is right for them. And one of the important things to understand is that this consent is a multi-layered process where in the first instance you go through it with the patient, you give the patient time, and often it is very important that they meet our very important colleagues, the breast care nurses, so that they can go through it again with them, show them pictures, show them real patient outcomes, give them the opportunity to speak to patients who had similar procedures, and give them the time, that cooling off period where they can come and give us the answer what is right for them. And I think I cannot emphasize enough that what is right for one person may not be right for the other one. Uh, just because we can do complicated surgery doesn't mean that we have to do it on everyone. It is very important that we choose the right patient, and more importantly, who not to do it on. Because for us, it's in a day's work, we leave behind a scar. However, that patient has to live that scar with the rest of their life. So it is very important we allow them the opportunity to choose correctly. And remember, breast cancer is not a surgery which needs to be done in a hasty way. It is not like a burst appendix that the operation needs to be done then and there or within the next 48 hours. So we have a little bit of luxury of time where we can allow our patients to consider all their options and come up with what they feel is right for them.